hear us. So, but I think I think it picks out.
All yours.
All right. So it's my honor to introduce Kishore Sandhu as the 2024 Broyles lecturer. I'm going to first talk about Edwin Nash Broyles and then introduce Dr. Sandhu. Dr. Broyles was the founder of the Hopkins Bronchoesophagologic Clinic. We named the clinic. I don't know that my slides are as important, but
also need to project your slides as well as have them on Zoom.
Great.
Andy, step straight out. Let me just say it's a pleasure to have you here. Thank you so much. We do have departmental pie for you, chocolates, and also a plaque. And want to say thank you so much for coming all the way from Switzerland to be with us tonight. Thank you so very much. I really appreciate it.
Dr. Broyles was the president of the ABA in 1953, and then the Laryngology Society, the ALA, 7 years later. And then this lectureship was established in 1981. Of note, we've actually been talking a lot about optics for airway, and Dr. Broyles was really a pioneer in optics. And then, of course, whole organ laryngeal sectioning with the anterior ligament known as Broyles ligament. And now to introduce Dr. Sandhu, who is chief of the airway unit at the Lausanne University Hospital in Lausanne, Switzerland. Dr. Sandhu is really a quaternary adult and pediatric airway surgeon. First medical school at the University of Bombay, followed by residency, also at the University of Bombay. And then he came over to Lausanne, where he performed both in a pediatric and adult airway fellowship over a couple of years, and then stayed on to run the airway unit. I've gotten to know Kishore through a number of meetings. And in addition to being a master surgeon, is really a amazing educator. This is a picture on the right from the airway dissection course that Dr. Sandhu led this past year in Lausanne. He's a wonderful colleague and a great connector. And then finally, you can see this is a picture of the experts at the Lausanne airway course this past year, and he and his wife Mukta are really amazing hosts that really stood out. Dr. Sandhu is going to share his expertise in both adult and pediatric open airway reconstruction for LTS, and talk about some of the lessons learned in the with the recent pandemic. Dr. Sandhu.
Okay, and then all right. Thank you so very much, the entire team in Hopkins, for this very kind invitation. And what we actually do in Lausanne is really adults and pediatrics. So my patients are basically from age 0 to age 90. Historically, this has always been like this in Lausanne, and this is how we have actually trained ourselves. I am trained in head and neck oncology, reconstructive surgery for head and neck oncology, trained in thoracic surgery, and aerodigestive endoscopies. So I think it's very critical, for us to know how the airway is from the inside and the outside if we really have to deal with these complex patients. I have nothing to disclose. So the idea would be to actually share with you how the pediatric side is different from the adult side. And really the question would be that, is it really different? And if yes, what are the major differences? So typically, we are looking at differences related to the anatomy, of course. Stenosis itself, now this is where it starts getting a little bit more intricate and interesting. And of course, surgery related, because I think it's really different regarding, the surgery itself is concerned in children and in adults. So let's look at the anatomy and what is different in these two age groups. So when I'm talking about two age groups, I'm looking at infants and I'm looking at adults. And it starts really with the position. So we know that in children, we have a high larynx. So it is going to be at the level of C1, C2, and slowly with time, it sort of, starts going down to the level of C6, C7, slightly lower down in an adult. The size of the airway itself is different in children. And what I mean by that, what is interesting is have a look at the infantile larynx and the size of the arytenoid cartilages. So in children, a lot is related to the size of the posterior glottis. And as we know that it is the posterior glottis, which is the airway glottis, and the anterior glottis is where we are using it for the voice. And in fact, in children, this area corresponds to almost about 50 or 60% of the posterior or the respiratory glottis. As against in adults, you have much more larger area in the posterior glottis. So the chances of us sort of committing some kind of a mistake probably are not forgiven in children. So you do have a margin of error in adults, not in children. So the intrinsic anatomy of the larynx are related basically to the cartilages. So in children, the cartilages are much softer, but more chances of melasic changes. They are much more harder in adults, but more chances of calcified cartilages, which makes our life even more difficult. And of course, we have seen this, where you have, in fact, 1 millimeter of subglottic edema is going to really cause a problem in a child, as can be seen here. And this is a child, in fact, in children, we do have a viral laryngotracheobronchitis or something called as a Foch. And this is just to show you that, when you have these secretions, which are really sort of, tough, sticky, stick into the larynx, and that itself is going to really crash down this child very badly, and the treatment is very, very tricky. Let's go down to the etiology. So what you're seeing, the blue stars, it means that it is similar in both the age groups, meaning post-intubation, post-tracheostomy, stenotic sort of lesions are common in both the age groups. Now, what is different are those on the left-hand side in children, basically congenital variety and acquired on congenital, meaning that if you have a congenital malformation of the cartilages, and if they have been intubated, you have a acquired on congenital stenosis, a mixed variety. Adults, basically, we are looking at post-trauma and idiopathic subglottic stenosis. Of course, you have a lot of other possibilities, but these are the main 4 in each of the age groups. And you have 2 of them being common in both the age groups. Now, it is very important in both the age groups to really do the endoscopy and early endoscopy in certain cases. For example, this is a 22-year-old man coming downhill on his cycle, and he has, the vertical part of the cycle, unfortunately, the horizontal part comes off, and the vertical part literally goes in his neck. Now, this is something which is very, very drastic. What is important is the timing of the surgery, timing of the endoscopy, timing of the treatment itself. For a moment, I thought this guy was airlifted from Germany, was got into Lausanne. And for a minute, I thought, larynxes, is it really going to function? I did not know. But the same thing, the same night, I operated him. I put really all the structures together, mucosa to mucosa, cartilage to cartilage, ligament to ligament. And eventually this patient, in fact, had a very, very good final outcome. And here is he literally singing. This is pretty interesting. But problems don't happen only in adults. This is a This is a 7-day-old child. The mother had a very difficult obstetric history. She had a prolonged labor. And unfortunately, during the delivery, the gynecologist had a big problem. He did, in fact, a lot of manipulations, which were quite traumatic. This is a kid who's being referred from Belgium. So Antwerp calls me, and this is what they report, that look, we have a surgical manipulation done during the delivery of this child. The endoscopy has been done on day 7, and what you actually see here is a tracheal separation. So when the delivery was conducted, unfortunately, you had the trachea literally pulled off. But again, here, the importance of doing an early endoscopy to pick up the right things and to treat the patient correctly. And then we spoke about four-Koob and congenital subglottic stenosis, where again, have a look here. We always are looking at the posterior glottis in a child. And here, in fact, you can see, in fact, it's an elliptic cricoid, and which means that the posterior glottis is going to be severely affected. Here, what you see is a congenital subglottic stenosis. Now, if you have a child who is born with subglottic stenosis, he is going to be intubated at birth. And if at all that happens, then it is going to be an acquired on a congenital stenosis, a mixed kind of a variety. And then you have these very drastic kind of situations where you have these urbanizations being happening all over the world, and you have something which is being put inside, but at the same time, you really, really want to do the right thing by doing the early endoscopy, which is not going to be just an airway endoscopy, it's going to be an aerodigestive endoscopy. What about the preoperative assessment in both age groups? Again, fortunately, it is the same in both the age groups. Now, what is important is that you need to have the entire gamut of the endoscopes, right from small sizes to the largest sizes. Now, if you are doing airway work in these two age groups, believe me, life is difficult. Quality of life is severely affected, and you need to be having all these instruments. So you are costly, you are expensive, but this is the way things have always been organized in my hospital. You need to look at the patient's general condition, the endoscopic workup. What is important is you need to do all those things to sort of, of course, take care of the acute condition, if at all that's the case, and really plan the patient in the future for some kind of surgery. Let's look at comorbidities. Now, here are the comorbidities which are common to both the age groups. We are looking at the lungs, the cardiac, neurological conditions, refluxes, obstructive conditions, eosinophilic esophagitis. And these are conditions which are specific in these two age groups. In children, congenital anomalies, dysmorphic conditions, swallowing disorders, mental retardations. So today, unfortunately, there's a lot being talked about prematurity. So kids are being born at 23, 24 weeks. Believe me, it's a nightmare. And they are intubated. So the neonatologists, they feel that, they're sitting just next to God. They have been able to salvage this particular 23-week-old child. But what they are not seeing are all those conditions. And now they have been given as gifts to us. Now, okay, you have a very complex stenosis in a complex child, manage him. And then in the adult world, of course, as we know, diabetes, immunosuppression, etc. So those are the main comorbidities that we are really looking at. When we're looking at the airway, preoperative airway endoscopic workup, we typically are starting always with an awake transnasal flexible laryngoscopy. Why? Because the airway is a dynamic sort of structure. You need to know the vocal cord mobility. You need to know, are there additional sort of collapses in the trachea, in the bronchi? Are there any intrinsic and extrinsic causes of airway collapses? We then sort of further go ahead and do an asleep TNFL, transnasal flexible laryngoscopy. And the idea being, again, to pick up obstructive sleep apnea syndrome kind of features. And that's where, in fact, you're looking at dynamic pharyngeal narrowings, vocal cord mobility, localized tracheomalacia. Again, remember the two age groups, they have their own problems. But as an airway surgeon, as an airway team, you need to pick up all these sort of problems. We then actually lower down, or rather deepen the plane of anesthesia, and that's where, in fact, the rigid endoscopies start coming in. You want to look at the site, the grade, the extent of laryngotracheal stenosis, the tracheostomy site itself. Remember that the airway is never measured in centimeters. All right, we are removing 4 centimeters, but 4 centimeters in a kid is probably his entire trachea. So we never talk about I resected or the airway has been removed, 4 centimeters of airway has been removed. We always talk in terms of number of rings which have been removed. In an adult, usually 1 centimeter corresponds to 1 tracheal ring and 1 intercartilaginous space. In a child, depending upon the age, which is going to be different in a neonate, infant, and a child at different age groups. We then go ahead and do a suspension microlaryngoscopy to really want to go and literally, if this is the vocal cord, you want to really go and move it. Is it a static fixation or an ankylosis of the cricoarytenoid joint, or is it a neurogenic cause of his vocal fold immobility? The best way of doing all these things is literally an endoscopy, because EMGs, a whole lot of these investigations, yeah, they'll give you an idea, but they don't give you the right diagnosis. You have an impression, but confirmation comes only with your endoscopy. And then, of course, you need to do a bronchoscopy, you need to do an esophagoscopy. In my unit, I insist that all my residents are very, very well trained in aerodigestive endoscopy. So we do all our endoscopic work preoperatively. We put in stents in the esophagus, in the trachea, in the bronchi, everywhere. Why? Because we know the airway much more better than our colleagues who are coming from pneumology. Of course, we take their help, but we prefer to do it ourselves. The reason being that we are the primary person who is responsible for the child. Others are collaborators. They will come and, of course, help us, but usually they will remain as visitors, and we are the primary referral doctor. We then create an endoscopic report. And what it means is that, we have photo documentation done of the problem and the site of the stenosis. And we create a sort of, a schema or a schema of what exactly we have found. We count the number of rings where the tracheostomy was done, number of rings which are below the tracheostomy site until the carina. And all this information is got on the endoscopy and not on the CT scan. We'll go ahead and do a transillumination in the neck. Remember, in adults, it's very difficult to know whether if at all you end up doing a resection anastomosis, you need to know, is your resection going to be behind the sternum? Is it going to be in the notch? As we know that with age, the trachea starts going more and more posterior in the mediastinum, and you need to be really be aware of where exactly my stenotic site is going to be. This is just to show you that the tracheostomy was done. It is nice and pretty well accessed in the neck, and it should not be a problem when we actually go down and treat. Let's come down to the airway grading system. What you see here is, in fact, the Cotton-Meyer grades. And of course, the gradings are from 1 to 4. Now, typically, this has been done based on what is the kind of air leak you get after putting an age-appropriate endotracheal tube. However, what we actually design is, or we understand that the decannulation can still fail even if you have a good age-appropriate endotracheal tube. When and why? If you have an associated comorbidities, your decannulation rates are going to be different. If you have glottic involvement, your decannulation rates are going to be different. And in those cases, when you have, apart from the various grades of stenosis or percentages of stenosis, when you have glottis and comorbidities involved together. So we actually now use the ABC sort of, classification along with the Cotton-Meyer, which is based on either there are comorbidities, as can be seen here, glottic involvement, or both. And this is the way we actually are able to understand the entire history of the child and prognosticate what is going to happen after the treatment. Switzerland is a small country, 9 million people, but majority of our patients, my patients actually come from abroad. So 90% of my patients are living in these countries and they come from abroad. The remaining 10%, usually they are coming from other university hospitals in Switzerland. We have 5 of them: Zurich, Basel, Bern in the German parts, Geneva, Lausanne in the French part. 70% are coming from outside Lausanne. So what actually we get in Lausanne is very little, but majority of our work is coming from external institutions. I myself do surgeries in more than 16 countries. And this actually adds up the connectivity, as Zandy was talking to you about, you have contacts with our colleagues in different parts of the world, and we do some surgeries which are outreach as well. Let's talk about now individual age group problems. In pediatric surgery or pediatric laryngotracheal stenosis, you have supraglottic stenosis, congenital webs, laryngeal atresias. I mean, the whole larynx just doesn't grow or is a problem there. So these patients typically have been delivered by an exit procedure, ex utero, intrapartum kind of a procedure. You have variety of subglottic stenosis, vocal fold fusions, posterior glottic stenosis, as can be seen here. And then you have these transglottic multilevel stenosis. What I'm trying to say is that you need to have a knowledge of treating all these various subsides of the larynx and the trachea if you want to have an established aerodigestive clinic and a team. Let's look at the adult one. Majority of our stenosis are related with the idiopathics or other systemic conditions, or we have the GPA, etc. Now, what is interesting in the idiopathic subglottic stenosis in these two sort of, slides is that here you can see a typical vocal fold and cricoid involvement. So it is a cranialized kind of a disease. And here, in fact, you can see the lower cricoid, which has been actually touched upon, and which is usually the case. Usually it starts between the cricoid and the first tracheal ring. The moment it starts getting cranialized, it means that probably the disease or iatrogenically, we're going to go into the cricoretinoid joints. Let's talk about radiological eels, which happens in both the age groups. In infants and children, it has absolutely zero value. Zero value is the word. That's the reason why Diego and we were talking about endoscopy, because that is what is going to give us the more information. This is going to give us more important information in that particular patient. In adults, it is possible that a radiological CT scan or other things can give information, especially if you have CT scans with 3D reconstructions. It will add a lot of information. But again, MRI and CT scan will play a role if there are mediastinal problems, typically in children who have extrinsic problems, cardiovascular, cardiac conditions. So it really needs what is that condition that really requires a radiological investigation. Remember, when you do a CT scan, you could have some secretions which are actually getting stuck inside the airway lumen, and which in turn is going to exaggerate your sort of grade of stenosis. Now, this is something which I really want to share with my younger colleagues in the hall. Now, remember, placing the tracheostomy is extremely critical. It shouldn't be sort of condemned as, oh yeah, it's a benign kind of a procedure. Anyone goes and does it. I think what we are really seeing is, unfortunately, the tracheostomy has not been put in the right place. Meaning that here are two cases, or are there two possibilities. You have a subglottic stenosis, as can be seen here, and the tracheostomy is placed very close to an incipient, meaning a developing subglottic stenosis. And in fact, here we have left almost about 6 or 7 rings between the subglottic stenosis, the developing subglottic stenosis. Why? Because here, in fact, you can do a single stage procedure, meaning if a tracheostomy has been done, you can get rid of the tracheostomy and treat the stenosis at the same time as a single stage procedure. Here, you are taking care of the stenosis, you are keeping the tracheostomy, so you can do a 2-stage procedure. Remember, tracheostomy is a potential site of future stenosis. So that can also create a problem. Again, as I said, in adults, a tracheostomy will not have so much problems. In a child, you'll end up having a tracheomalacic kind of a situation around the stoma. You will have some problems to face there. And that's where, in fact, we need to be trained in both types of surgeries, typically cricotracheal resections and laryngotracheal reconstructions. The main principle of a cricotracheal or a PCTR, it is always a partial cricotracheal resection, meaning we keep the posterior cricoid plate, which in turn, in fact, is articulating with the arytenoid cartilages. We get rid of the anterior arch of the cricoid, the tracheostoma, and this entire thing is actually removed. We mobilize the trachea from the mediastinum and then attach, in fact, the trachea with the thyroid cartilage. Now, again, coming back to the previous slide, let me just take you to that. If at all, conventionally, if the tracheostomy was done between the second and the fourth tracheal rings, that would only mean that more of trachea, which could be a normal trachea, is going to be resected. So there are more problems which are going to be faced if you have resected longer tracheal segment along with the cricoid. That's the reason why you want to keep as much trachea as possible. Remember, God has made only one trachea, which has got one certain length, which has got a certain dimension. The moment we start playing around with it too much during a tracheostomy, the things start getting more difficult. It is going to be unforgiving if at all we do a certain procedure which is not indicated in that particular child. Let's look at specific problems in the various age groups. We saw this a little bit earlier. In adults, yes, you do have some individual morphological problems, short necks, long necks, obstructive sleep apnea syndrome kind of features. Cartilages are much more thickened, calcified, etc. In adults, it is always a little difficult to mobilize the trachea if, in fact, a sternotomy has not been done. If a sternotomy has been done, the thing is really straightforward in the sense that you're going down to into the mediastinum and really pulling the trachea up. In a child, in fact, the cartilages are much more softer. So peristomal tracheomalacia, suprastomal collapses are more common. They will be associated with some secondary airway lesions, again, typically related to upper airway or obstructive sleep apnea. And they could have some kind of problems related to the distal trachea, meaning they could have a tracheobronchomalacia, some malformations related to the neurological conditions. And of course, a gastroesophageal reflux in children do play a big role. What is important are those conditions which are common in both these situations. A cricoarytenoid fixation problem, meaning it is going to be even more problematic in a child because the posterior glottis is just fixed, it just doesn't move. However, the children surgeries are much more forgiving as against adults. Adults, the moment you start sort of playing around with the arytenoid cartilages, etc., aspiration starts coming in, dysphagia starts coming in. Children, because of their anatomy, fortunately, they are much more forgiving in their post-surgery management. Site of tracheostoma is really critical. So remember the transillumination that we saw? Now imagine the same thing is not seen, meaning that this is retrosternal. So you already have an idea that we're going to head up into a small problem there. Probably this patient is going to require a sternotomy. So if at all you're doing a resection anastomosis, so you can get this information, which unfortunately you cannot get on a CT scan. A long tracheal loss is again something which unfortunately we have not been able to find a solution. If you have a long tracheal segment which is damaged, we do have an issue. And the same thing with a long malacia or long segment tracheobronchomalacia. In both the age groups, if I have to select a single stage procedure, again for younger colleagues here, single stage means that the subglottic stenosis is going to be removed concomitantly along with the tracheostoma during the same surgery. This is a single stage procedure. And typically the indications would be you have a purely subglottic stenosis, so a single subsite of stenosis. Vocal cords need to be functioning, and overall general condition of the patient is pretty good. A double stage procedure or a two-stage procedure is typically done in those patients, or rather, what is a two-stage procedure? Meaning we keep the tracheostomy lower down and then treat the stenosis and decannulate or remove the tracheostoma in the second stage. Remember, tracheostoma or doing a two-stage procedure in an adult is fine. In a child, because of tracheomalacic problems and suprastomal collapses, etc., really it needs to be thought about correctly because it is a potential site of future stenosis. But a two-stage procedure is done in these two main indications for local reasons and for general reasons. Local reasons would mean that you have a multi-site stenosis, and general reasons are typically related to comorbidities. So you have someone with severe morbid obesity, has some neurological conditions, cardiovascular conditions, lung conditions. You would like to go be safe, remember security first, you probably will choose to do it in 2 stages. Let's look at the surgical technique itself. Now, laryngotracheal dissection, same in both age groups. Resection lines, same. Tracheal stump mobilization, same, plus minus a sternotomy. Laryngeal drop is an interesting concept where, in fact, what we do is we get the larynx down and the trachea up. So you have a laryngeal drop and a tracheal mobilization. The larynx needs to come from up to down and trachea needs to go from down to up. It's slightly different and is better tolerated in children as against in adults. Remember we said that, the children anatomy is more forgiving. So it is more forgiving for a laryngeal drop. That doesn't mean that it cannot be done in adults. We do it right, left, and center. It depends upon what kind of laryngeal drop you are doing. Are we doing a suprahyoid drop or we are doing an infrahyoid drop? What we do is a suprathyroid drop, which is a totally different way of doing a laryngeal drop. Technical details, we can discuss a little bit later. But what I'm trying to say is that children adapt to the laryngeal drop better than adults. Anastomosis, again, is different. It is better tolerated in adults, but a longer segment can be removed more in a flexible cartilage in a child. And what is interesting in a child is that you need to reconstruct or reclaim the new or neo subglottis. We'll see how it is done. So there are 3 ways of reclaiming the new subglottis. The way we do it is that, of course, you see here you have the trachea. All the entire surgery is done in front of the cricothyroid joint. Why? Because the recurrent laryngeal nerve is behind the cricothyroid joint. So if we stay in front of it, we should be away from the recurrent laryngeal nerve. We place some sutures in such a way that actually it lateralizes the infraglottic mucosa. The second way of doing it is basically we do a subcommissural inferior midline thyrotomy. You will see a little bit later why and how it helps us. Basically, what we try and do is something like this. It creates an inverted triangular kind of sort of expansion. And that's where, in fact, we will be putting this part of the trachea. So this area remains expanded. And the last thing that we do is we drill the posterior sort of, cricoid plate. So that additionally gives us a 1 millimeter. So 1 millimeter here, 1 millimeter here, 1 millimeter here. So 3 millimeters in a kid with 6 months age is already a lot of subglottis that we have created. When we do our thyrotracheal anastomosis, it remains the same in both the age groups. It is done. Basically, the posterolateral anastomosis is more important. And in fact, this is placed submucosally in 1.5 rings of the trachea. Submucosally, why? Because you don't want to strangulate the mucosa on the inside. If you're going transmucosal, and if you're tying it, the mucosa is going to get suffering. It's going to go into ischemia. So we always put the suture submucosally. And when this is passed posteriorly in the posterior cricoid, it is passed in the subperichondrial plane, and the needle comes out in front of the cricothyroid joint. Why is it subperichondrial? Because again, this is a surgery that you have to start thinking 3-dimensionally. You have the posterior cricoid plate. Behind you have the posterior cricoarytenoid muscles, and just in front you have the posterior perichondrium. So again, imagine that if the needle is going, radically into the posterior cricoarytenoid muscle, you will end up having a blockage in the vocal cords. So it is passed in such a way that, in fact, you stay in front of the cricothyroid joint and is in front of the posterior cricoarytenoid muscle. And then, in fact, the needles are again reinserted back into the cricoid. And in fact, the knots are tied on the inside of the cricoid. So you have a very, very good mucosa to mucosa contact. And then, of course, in the final anastomosis, what we try and also do is an internal Grillo stitch, meaning the inferior border or inferior portion of the posterior cricoid is stitched to the tracheal ring, and this in fact is going to reduce the tension on the anastomosis. A couple of examples. This is a 6-month-old kid, multiple procedures done in the subglottis trying to expand it, and this is in fact a single stage cricotracheal resection, and this is the same child at 18 months. So you have a mucosal, it's all about mucosa now. If you are able to bring back the mucosal functions, mucosal, way of sort of, in the subglottis, I think the results are going to be much more better. Let's talk about in adults what happens. This is a 57-year-old sent from Paris. So Hôpital Foch's hospital is dedicated thoracic surgery hospital for pulmonary transplantations. So in fact, she had idiopathic subglottic stenosis. She had undergone multiple endoscopic treatments. She started getting right side hypomobility of the vocal cords, meaning the disease is now getting cranialized, either the disease process itself or the multiple endoscopic procedures which have been done. The same patient, a single stage procedure, resection anastomosis, 4 months later, and we have a follow-up of this patient after 2 years, she is looking exactly the same. What is different, or what is that we are looking for? Look at the mucosa quality. Now, this, if you are able to get into the patient, this is what is the game changer. So it's all about the mucosa. It's all about the vascularity of the subglottic tissues. A second patient. This is a 54-year-old female, grade 3 subglottic stenosis, undergone multiple endoscopic procedures, obese, obstructive sleep apnea syndrome. And again, in fact, here you can see that the right vocal ligament is getting affected. Same story. You have a cranialized disease. So again, remember we said that we want to now reserve a 2-stage procedure for a patient, but with comorbidities. This patient was obese. The patient has had obstructive sleep apnea. So again, security first. It doesn't make sense to be very heroic and go ahead and do the surgery. So we did a 2-stage procedure. We put in a stent, which is sort of made in our hospital. I'll show you the stent a little bit later. And this is the same patient at 12 weeks. So we were now able to go during the surgery. We opened up the cricoarytenoid joint on the right side. We removed the disease. We rotated a local flap and tried to sort of have a complete mucosalization of the subglottis of the right cricoarytenoid joint. And this is what the patient has. Eventually, the patient is decannulated successfully. Now, you do have situations which can be quite tricky. Like, for example, if you have really, really cranialized disease, not just posteriorly, but even anteriorly, as can be seen here, would we really go ahead and do a cricotracheal resection in these patients? Not at all. Unfortunately, this is a patient who will require just endoscopic treatment, or in a patient like this, probably who's going to go in for a tracheostomy sometime in her life, or she has to be ready for multiple endoscopic treatments. We get a lot of these patients coming from abroad. So finally, the thing is that we need to give some kind of very clear-cut guidelines. It is going to be this, it is going to be this, it is going to be this. Because the contact is not so easy. So we need to tell them that, fair enough, if you are able to do an endoscopic treatment, go ahead. And if at all the patient requires a trachea, unfortunately, you need to talk to the patient now. The patients will go abroad, go for vacations, etc., etc. Landing up at some other place and getting intubated, especially when that institution doesn't know what has been done or what the patient has, in spite of these health passports and other things are a little difficult for these kind of patients. Let's sort of switch gears and go into extended cricotracheal resection. So typically what we're looking at are those cases where you do a posterior commissure enlargement by using a rib cartilage graft and plus a subglottic stenosis. So it is basically an expansion procedure plus a resection anastomosis. It has got 4 basic steps. We do a full laryngofissure. We excise the entire disease in the subglottis. we do a posterior cricoid split. We mobilize a rib cartilage graft, which is sutured so as to cause an expansion. We mobilize the trachea in such a way that the posterior tracheal membrane is now going to be sort of, sutured way high up and is going to be sutured entirely to the posterior glottis. This is a two-stage procedure. We will put in a silicone prosthesis, which is fixed in the supraglottis and in the trachea, as can be seen here. You have the tracheostomy and then finish off with the anastomosis. This is a silicone, soft silicone, high-grade silicone stent, which has got an endolaryngeal contour. What I mean by that is that this is the same shape as the endolaryngeal contour. The beak of the prosthesis lies in the anterior commissure, so this is best suited to have the best endolaryngeal contour. It has got a V shape in front. So when we actually put the stent inside the larynx and when we do a check endoscopy, we look for this V mark. We know that the V mark, if it's facing in the direction of the anterior commissure, that's where my anterior commissure is. If it rotates, it means that things are getting a little bit difficult. The entire stent has been twisted and has moved. We have also additionally metallic templates that allow us to choose the right size and the right length of the stent. Remember, the stent should not be too short, otherwise you will have tracheostomy-related problems. It should not be too long, otherwise the lower end of the prosthesis will go into the stoma and then recannulation might be a problem. This is just to show you that the stent is fixed in the supraglottis and in the trachea. It can also be fixed endoscopically, but here we are showing you how we remove the prosthesis. It is a hollow stent, so we do it under suspension microlaryngoscopy. This is the tracheostomy. Using microlaryngology scissors, we actually just create a hole on the head of the prosthesis, go down, actually look for the fixation sutures, cut them off, and the removal of the prosthesis. So this is again the stent in place. We grab the head, we sort of create a hole on the top of the head, go inside, fetch for the sutures, cut them off, and this is how finally, in fact, the stent comes out. A couple of examples. This is preoperatively glottosubglottic stenosis, and this is postoperatively. This is a 33-year-old sent again from Hôpital Foch. 2 times surgery has been done following a cystic fibrosis induced, or rather not induced, but a bilateral lung transplantation for cystic fibrosis. This is what she came to us with. Again, please note that she has had resection anastomosis 2 times by the thoracic surgeons who were there. What you see here is some sutures. These are proline sutures. Again, you have these secretions, which are blocking the trachea, blocking the bronchi, etc. Again, what we did again the resection anastomosis, because if you have a stenosis like this, you can never salvage this by any other surgery but a resection anastomosis. And this is what we did. And this is the patient at the end of the surgery. We did it as a 2-stage procedure. And finally, in fact, the time to decannulation was about a little bit more than 3 months, but finally she did pretty well. Last 5-10 minutes, regarding the postoperative care, again, in adults, we extubate the patients on table in the operating blocks. They're always kept in a sitting and semi-reclining position. No ambulation before the 10th day. And we usually do a re-endoscopy after about 10 or 12 days' time. This gets a little tricky and challenging in children. The reasons are that this is a small airway. They usually will have vocal fold edema. And that's where, in fact, we use a lot of non-invasive ventilations. So CPAP, BiPAPs are used typically in these kind of patients. Remember, we always sedate them because small children are not cooperative. And in children as well, we actually sort of do not ambulate them for at least about 2 weeks postoperatively. Let's look at complications. The main complications are related to anastomotic dehiscensis, restenosis, recurrent laryngeal nerve injury, and of course, you will have in the future some kind of tracheostoma-related problems. That's the reason why select your patients correctly to avoid any kind of problems. We have looked up at our series in pediatric 191 pediatric cricotracheal resections. And we've always seen that, longer the resection means cricoid and more than 6 rings, the chances of anastomotic dehiscences start going up. But if it is lower down, you are able to salvage these kind of patients. So just to conclude the first part of this presentation, that yes, major differences do exist between the two age groups who are undergoing a cricotracheal resection. However, the preoperative assessment should be similar. Clearly, it is a team game. So you need to have everyone in the team on the same page. And of course, comorbidities are going to highly influence your outcomes. So always remember, cricotracheal resections is a beautiful surgery, but it is surgeon dependent. And you need to have the entire team to help you to get out of these kind of problems, if at all that is the case. Just last 5-10 minutes, a little bit of our experience in COVID patients, because I think COVID patients are quite tricky. So in 2020 March, Switzerland, announced, the Confederation announced along with the EU that, this is a pandemic, we are realizing, and we have to go in for a lockdown. And immediately the European Laryngological Society, we got together and we said that, we need to sort of, write up something giving certain guidelines for our colleagues regarding COVID pandemic. And what it mentioned is that we really need to have high level of suspicion of laryngotracheal stenosis development, because all these patients who were intubated, they were having comorbidities, they were being tracheostomized. But I think the guidelines to me could have been better than what actually were given in those days. So what happened in these patients? So you have the endotracheal tube, you have a lot of posterior glottic and subglottic stenosis. So this is the endotracheal tube, which typically affects the posterior commissure, the medial side of the arytenoid cartilages. You have a problem in the subglottis. And then, of course, with this tube, with these pronation maneuvers that they had, of course, we had a lot of problems in the posterior commissure. And also the tip of the endotracheal tube lesions anteriorly. Posterior glottic stenosis, so you could have a stenotic band in the posterior glottis. It could extend as a cricoarytenoid ankylosis either unilaterally or bilaterally. The result is the same. You have both vocal cords immobile, and the process either could immobilize one or both vocal cords. These in red are basically mechanisms which were typically related to COVID-19 treatment and which caused either prolonged intubation or tracheostomy-induced problems. For me, these 4 are very interesting to note, that all these sort of, prothrombotic and antifibrinolytic states of patients predisposed the mucosa to more ischemia. High viral replication in the mucosa has weakened the mucosa of the trachea and the larynx. Chronic and high-dose corticosteroids has thinned down the tracheal mucosa. And of course, with the PaO2 and FiO2 ratios being lowered, they have actually induced hypoxia in this mucosa. Then there are 2 other things which have happened. The pronation maneuvers, emotional and physical exhaustion that happened with the caregivers actually led to have more amounts or more severity of iatrogenic trauma. And then finally, we know that they all have existing comorbidities. So now, with all these things in place, we actually narrowed down to understand what are those specific problems in these patients. There are 2. Diseased laryngotracheal mucosa and a problematic cartilage framework. Now, why and what has happened? Decreased vascularity has given us a lot of complications. Now, what am I talking here about? I'm talking about now those surgeries we will be doing for these patients who have multi-level stenosis. And these are coming with some problems. Some of them now have entirely posterior cricoid, which is leased. There is no posterior cricoid. And this has happened. Multi-level complex laryngotracheal stenosis. And because of a lot of peritracheal extrapulmonary sort of, inflammation that we have seen, mobilization of the trachea is not so easy. And of course, the comorbidities, obesity, etc., do have a role to play. Laryngeal exposure is a nightmare. And that's why, in fact, we have very limited optimization of the airway results. My hospital, all over the world, they kept on saying that, you should not be doing endoscopies. But believe me, I had a chat with my hospital management, and we said that, look, pandemic comes, and we see a pandemic once in 100 years, once in a century. So this is the best time that we can gather all of this proteomic studies and symptoms. We are looking at in plus long durations. So these all kinds of, patients that we saw with the prolonged duration, and then all the reasons what led to that, all the legal problems, etc. And here, in fact, you can see a child, a child, from Greece with a very severe, long treatment. So we have suffered. So in that suffering, we thought that, why can't we actually have an idea of what is different in these patients as against, patients who were operated and treated in the non-COVID period. So in our hospital, we had about 238 ICU hospitalizations, 64 had required a tracheostomy. We actually matched, we had about eventually 21 patients, 7 required endoscopic procedures, and 14 underwent an open airway surgery. 13 of them were referred from external institutions, and a couple of them from abroad. So we matched these two, and all of them required some form of open airway surgery. Of course, this is a very heterogeneous group. Of course, we understand all the biases in selection criteria, etc., etc., etc. But what we wanted to see is what were the outcomes in the two periods, COVID and non-COVID, and then we compared the clavy and Dinto complications for these patients. And what we realized is that in the COVID groups, majority of the comorbidities were related to either obesity or hypertension. And regarding the outcomes, the overall recannulation rate in COVID patients was lower as compared to the control group. Complications we saw in almost all patients. 2/3 of the patients had high-grade clavy and Dinto, meaning, just for younger colleagues, clavy and Dinto is severe complications. And 1/3 of them required revision surgery in some form or the other, either as an open or an endoscopic procedure. Voice results were poor in all patients because the glottis was always touched. Some cases. This is preoperative, so you have a glottis subglottic kind of a stenosis, and this is following a cryotracheal resection anastomosis. Patient coming, this is being sent from Austria. This is a patient who was referred to us from Slovenia. This is preoperative posterior aortic stenosis. She had a pharyngolaryngeal fistula, underwent a surgery, and then, in fact, here you can see the blue dye behind. We love to do, just to be sure that we're not looking post-operatively, we are not looking at some problems of a persisting pharyngolaryngeal fistula. Eventually, the patient is decannulated, eating well, not a problem. And this is the same patient was from Greece with a very large spinal fistula. So here is the fistula, here it is the trachea, behind is the esophagus, and here the fistula at the same time. Just to conclude this final sort of mention on COVID patients, the pandemic is over, but has left several airways crippled and scarred. And I think early referral to a specialized center is very critical. I thank you very much for a kind and patient hearing. And thank you.
Questions from the audience?
Yeah, hey, thanks. Appreciate it, Tom, very much. I have some questions for you about any approaches you're doing for sort of post-intubation, posterior glottic insufficiency. Many some of the options that people talk about are doing, other local tissue flaps or doing that sort of the opposite of an LTR where you actually take some coagulated out to try to get closure.
So in both cases, if I understand posterior insufficiency, it means that is it a stenosis or is it an expansion? Okay, so if it's an expansion, and both vocal cords are now fixed, they don't move. They can move. So sometimes we do use fillers in adults. Some kind of hyaluronic acids, Juvederm, renew voices. So all these things are a possibility. But again, it's going to be acting as you're winning on the aspiration side, but you're probably losing out on the breathing. So this is going to be always an issue. But the only possibility is that if these are very old patients, then you have to talk to them that look, this is going to be a balance between the airway and the symptoms that they're coming to you with. Aspiration.
Thank you for your presentation. I was wondering, how long do you leave this stent in?
So we leave the stent for anywhere between, depends on the case, but the longest I have left it is for more than a year. And every 3 months, we remove the stent and reintroduce it. Normally, typically, it will be anywhere between 10 to 12 weeks, 3 months. And I do know that it's going to be 3 months. That means granulations. Believe me, we don't have granulations with these kind of stents. This is high grade, artisanal kind of made stents, and they are very high quality. I can tell you that we have very, very good results with them. Alex has been in our case. There are a lot of people who've come to it. We get about 50 to 60 visitors a year, and I can tell you that no bluffing, it works. Yes, but it really depends upon the softness of the stent. If you have hard stents, of course they're going to granulate. So it really depends upon how you're using it, when you're using it. But regarding our stent, laryngotracheal mold, we have left it for short term, long term, very, very long term.
You're always suturing it back.
Yeah, I like to suture because I like to sleep well in the night. The reason is that you don't want it to get expulsed. And the reason why you're suturing is because once it is sutured, it's not going to, it's moving up and down to the larynx. So you don't have any sort of shearing forces. Plus remember that if you have a cylinder, I'll teach you, a cylinder is not going to, it's going to have some amount of gaps between them, So the shearing forces are going to be very tricky. So either you will have a shearing force or a gap either behind when they'll aspirate. Even if you have closed your tube, you can do a lot of things, but you will have some problems with something which is not attaining to the laryngeal contours. Yeah.
Question about the stents. So
Yep.
first of all, are they commercially available? The second, they're not cannulated, they're hollow, so you actually uncap them when you remove them.
Yeah. So the answer to the
we use hollow stents and they're cannulated so that makes me sleep better.
So the first answer to the first question, no, they're not available because we have issues with the FDA. So the MDR, the Medical Regulation Devices or the Devices Medical Devices Regulation Act, it gets very, very tricky. The stents are hollow and fully covered or are capped at the top and at the bottom. And the reasons were that initially we used to actually have the lower cap to be stuck inside, by using glue. What we realized is that all these fixations, the cap is not fixed, it can come out. We can put some sutures in that. They were not factory made stents. So we had to prepare a stent and fix the cap. So that was the reason. How do we remove it? Because it's a hollow stent. We can just grab the upper part, cut that. We have 2 sutures. We always fix it twice, doubly. So cut up, cut down, get the stent out. So the chances of expulsion in our series of more than, I would say, not only in Switzerland, but even abroad, we have used it in more than 350 cases. We must have had about 4 or 5 expulsions until now. But again, what we tell the patients as well, if you have an expulsion, not to worry, because you have the tracheostomy in place. Don't worry, either patients actually cough it out, or it comes out the next day by natural, during the toilets. So no, we really, and then they just have to come over again, and we introduce the same stent. It can be inserted endoscopically as well. So we just introduce it endoscopically and, just wait until you actually decide when you want to remove it. So yes, we take a decision based on the extent of the stenosis, severity of the stenosis, depending upon the patient himself or herself, that, there are some comorbidities that, we want to keep it for a long period of time. So there are biases, but honestly, for that patient, the treatment needs to be personalized. That's the way it is. Yeah, sorry.
Do you do anything special for immunosuppressed transplant patients when you're a CTR?
Again, if they are on corticosteroids, if it is going to be playing a role in all the complications that we spoke about, I think the best alternative, look, CTR, LTR, laryngotracheal reconstructions, cranicotracheal resections, these are only flight tracheoplasty. These are only surgeries that are sort of designed to correct stenosis. It's not necessarily true that we have to use a CTR. So you need to select the right case and then sort of select the right surgery for that. So if a CTR is required, a CTR is required. And then if it is an immunosuppressed patient, then of course we'll talk to the concerned doctors that what are the chances we have selected a very aggressive treatment, aggressive surgery, because it is required for the stenosis. But if your treatment is going to, give rise to all these complications, related to corticosteroids and other things, probably we'll have to rethink we'll have to reinvent the wheel again. So it is not, it's basically really personalizing the treatment for each individual patient. It's not true, again, security first. So we do not compromise on that. And then, of course, talking about various types of surgery that really depends upon what we get in these patients. Does it answer your question? Yeah.
The question you mentioned, for some of the resections, you're doing this, that internal grillo.
Yeah.
That's sort of what
Yeah. Yeah.
But, we've seen and know it's been reported, so if you're overly flexed, you can get interspinal.
Yeah.
ischemia.
Ischemia. Yeah.
And so are there other tricks? Do you often add CR or external grillo with it, or particularly with the pediatrics where you just can't, like sedate them continuously with it for 4 weeks, but you don't want them to be overly flexible?
So thank you for the question. So the ischemia of the spinal and the spinal arteries. So I was very surprised when I got a call from Kuala Lumpur that not me, but they had done something over there, and the patient has become quadriplegic. And I said that is a tricky one, and probably this was related to the excessive flexion and probably compression of these vessels. They actually removed that, and in fact, the patient did well. I mean, he had a reversal of his neurological sequelae. We do the internal grillo stitch. We sometimes, there are other ways of really reducing the tension on the anastomosis. External grillo, the problem is that the palpation of the neck, observation of the neck, keeping a close contact with the patient to see whether he's developing any kind of complications is much easier without the external grillo. Unless, having said that, if it is required, it is required. And then we make a mention of that to all our residents, to all the nurses, saying that, look, we have put this stitch. That doesn't mean that you should not be palpating for subcutaneous emphysema. That doesn't mean that, you don't keep an eye on the clinics of the patient. So be very clear understanding that, okay, we're doing this for a certain reason, but that doesn't mean that, we are going to forget about other problems which are more important. I don't know whether they have external guys they can talk to us. I don't know. People who are outside.
Questions from our Zoom attendees? Well, Kishore, that was really a wonderful lecture.
Thank you very much.
And the pictures were extremely clear, as was the whole presentation.
Thank you very much. Appreciate it. Thank you. Oops.